So obviously, as you see, this entire workshop will be recorded. And again, I'm Dr. Michael Giuliano. I think we've all sort of met in brief when we did the initial Rattle introduction back in June. But I'm a clinical neonatologist by training, and I am the assistant dean for faculty, resident, and student development. I think I've made the point multiple times, both on this workshop and in other settings, that I think that the residents are clearly the most central and most critical part of the educational continuum. And indeed, you hold far more power and far more influence than often sometimes you realize. And that's why we've made this program really focus on the house staff. If you'll recall, when we met in June, we gave a broad overview of the RATTLED program. And for those of you who are not familiar or don't remember, RATTLE stands for Resident as Team Teacher, Learner, Educator, and Diagnostician. And again, we've gone far beyond the typical Resident as Teacher program and really have talked a lot about how residents need to be all of these things. And this morning in particular, what we'll be talking about is focusing on your own learning and your own self-directed learning plan or individual learning plan. And we'll also be talking about some of the foundational ideas behind becoming a teacher, which is absolutely critical to really understand. So we're going to have an opportunity today to really have some really basic ideas about your own lifelong learning plans. We're going to talk a little bit about both the organization and some of the basic teaching skills that are required. And of course, we're going to introduce some basic educational ideas that are so important. I think it's very critical for you to recognize where we'll be going. We'll be doing a series of these large Zoom-based workshops, Zoom or live, depending on the setting, but we'll be doing a series of these large group workshops over the course of the next few months. Actually, we'll be finished by September. But these workshops, there'll be 3 in all, focused on the new residents, the interns, and it'll just basically introduce these basic concepts in much more of a lecture format. That will be followed by Rattle Part 2, which will happen within your own departments in small group settings where you, instead of just hearing about these things, will be using these concepts. And with that in mind, there'll be a number of homework assignments that I'm going to mention as we go through this that I think will be critically important for everyone to indeed do, because those will be critical elements of the workshops that we'll be doing live. And with a little bit of luck, we'll actually be in some of those, so we'll get to actually meet each other in person. This is regrettably mostly a lecture, but if there's any points that I make or Dr. Knoll makes as we move through this material, please don't hesitate to chat in your questions or comments and or unmute, and then please let your voices be heard. This is not meant to be, a straight lecture where everyone just sits back and listens. I would encourage you to make comments and or to ask questions as we move through it. And again, this morning's learning objectives, and as educators, now that you're becoming educators, you know that we always begin with learning objectives. We're going to really touch on, obviously, some of the critical attitudes that are absolutely essential to be lifelong learners. Again, we're going to talk a little bit about your own individual learning plans, which hopefully you've already started to create in the context of your residency. We're explicitly going to talk about the master adaptive learning model, which I think is a useful way to sort of get going and having a plan. We'll touch briefly on the finding information framework, which is utilized by our medical students at the School of Medicine. And then, of course, we'll talk a lot about actually your personal organizing system for all learning, which I think is absolutely critical to really address. So what's your problem? And how are you learning now? And I would actually probably argue that up until this point in your education, you really aren't self-directed learners to a large extent. You've been driven, your learning has been driven by the coursework that you were doing in med school, and even in your clerkships. I'm sure that your learning was driven, by someone giving you some pretty direct ideas about what topics were most critical and where you really should be going. Although in the clerkship environment and in electives, you obviously had much more leeway. But the reality is that now you're really, to a large extent, very much on your own. And you're on your own in the sense that you're in a world where you're going to be learning from many, many sources. The knowledge that you'll be picking up is very clinically relevant and has a shelf life of about a year and change. So you've constantly got to edit it. You know, you're dealing with an explosion of information. You just can't keep up with all of the literature that's coming and all of the changes that are happening in guidelines. And of course, you got to organize all this over the next 40 years and garner all of the information and wisdom that you develop in the practice of medicine and taking care of patients. And you got to keep all of this straight, and you got to keep it all organized, and you got to be able to keep track of everything. You need a plan. And I would actually argue you need a plan yesterday. Some would say, I'm just getting started. But actually, the best time is right now, as you're beginning in your careers, in your various specialties. This is really the ideal time for you to stop and think about, how am I going to organize all of this learning from all of these resources that are constantly changing over the course of the next 10, 20, 30, and 40 years. My experience is that most residents have individual learning plans developed mostly with a focus on doing well on their boards. Now, I understand you need to pass your boards. There's no question that that still needs to be an essential part of what you do. But the reality is that this isn't just about your boards. It's far more than that. And indeed, I would argue an individual learning plan addressing your board passing is but just a small part of what should be a lifelong learning plan, really devoted to being able to handle all of these issues and questions that I've raised. And I think having a self-directed lifelong plan is so critical. It really, I think, is the secret sauce of really keeping up to date. There really is no alternative. And everyone wants to maintain their knowledge base, their skills, and their attitudes. But let's be honest, you probably already have seen faculty and senior attendings who have gotten out of date and are anecdotal, and you would not want them taking care of your own family members. And you clearly never want to become that attending. And if you don't have a critical self-directed learning plan, that's exactly the fate that almost all of us will face unless we really, really work on it. I often hear from house staff when we talk about them as learners and teachers is they're so hesitant to sort of put themselves out there because they just don't know enough. Well, I have a secret to tell you. I've been doing this for 40 years and I still don't know enough. And I will probably never know enough. And indeed, the most important thing I do in my own personal lifelong learning plan is I constantly sort of think to myself, do I know that as I'm rounding or I'm interacting with students? And I would actually argue that the three most important words in your own self-directed learning plan is an honest, I don't know. Now, many would argue, well, that makes you look, like you're not competent in front of the face of the students, et cetera. The reality is that what it does is, as long as you model, I don't know, followed by finding out what it is you're modeling precisely the behaviors that we're encouraging, which is curiosity, and then of course, acting on a self-directed learning plan where you fill in basically the things that you're missing. And again, the master adaptive learner model is the model that's been put forth to try to organize that initial curiosity, that initial questions that you raised about things that you don't know, and how to structure learning around those issues. For those of you who have not seen the master adaptive learner model, the AMA has put this model out a number of years ago. It should be fairly familiar though, because it mirrors the plan, do, study, act model of quality improvement. The only difference here is that the cycle is plan, learn, assess, and adjust. And the idea here is that you systematically will be looking all the time for opportunities for learning, things that you don't know. So to keep a running list, my own personal habit is to keep a little index card in my pocket that I write my questions for the day. And if I'm paying attention, I always have 4, 5, 6, 7, depending on how clinically active I am that day. So I have a manual plan for keeping track of what I don't know. And then of course, I have obviously am motivated to, because I'm in front of house staff and students all the time, to actually prioritize those questions, pick the thing that's most important, then go get a piece of literature and or a reference that is absolutely critical. So a self-regulated learning module really is a purposeful way of indeed looking this material up in an appropriate way. So it's all about what resources that you utilize. It's about prioritizing what it is you find out, having the motivation to do this all the time, sort of self-monitoring and self-assessing yourself in a constant way, reflecting on what you know and what you don't know. So it's really requires an attitude of honesty and humility too. And of course, the habit of indeed finding the information out. This model can actually get pretty complicated, but in reality, it's really what don't I know? What's most important that I go find out right now and indeed find the right resources to do it, learn that material and then put it into your practice, assess it, and then the cycle goes round and round and round. I would strongly suggest, the AMA has this book called The Master Adaptive Learner. It's not particularly long. It's actually, it looks just like this. It's got a little purple cover, readily available, not particularly expensive, but I would strongly suggest that become part of your library. And I would recommend, that particular book to you for help. And again, the Master Adaptive Learner talks about certain core attitudes that we all have to be able to maintain this lifelong learning perspective. And that's this idea of always having a degree of curiosity, obviously motivation that I've just spoken about, having this particular mindset that this is just basically part of my life work every single day, that ongoing learning is just part of my job every single day. And of course, the resilience to realize that you're going to have gaps and holes and times where your knowledge base is inadequate, but recognize that those are opportunities. And indeed, we need to all recognize that we're going to have those kinds of holes all the time, use them as opportunities, not necessarily as things to beat ourselves up. I love this particular quote about curiosity. It actually came from a young girl who won the contest to name the rover that's currently on Mars. She named it Curiosity. But I just loved the way she put this. I'm not going to read the whole thing, but curiosity is that everlasting flame that burns in everyone's mind. It makes me get out of bed in the morning and wonder what surprises life will throw at me that day. Imagine waking up every morning with that sort of quote in your head. I think it's just wonderful. And she's only 12 when she did this. I'd be very curious to see what she becomes. It's also part, by the way, of your professional responsibility and the commitments that you made when you took your oaths to become a physician. So one of the homework assignments that you have is indeed, I'm making a number of suggestions about a plan for sort of looking for opportunities for where your own knowledge is weak. But I'm actually going to ask that you create a really written, specific individual learning plan for life. And it'll be part of your homework for the RATTLED 2 workshops that we'll be doing. And indeed, I would suggest a number of ideas about what those elements should be, not just preparing for the boards using some prep book. Often your programs are going to have regular workshops that have a strong focus towards passing your boards. That program's sort of going to be in place and going to be presented to you. So it's obviously that will be part of your individual learning plan, but it has to be, as I've already suggested, far greater than that. So how are you going to be looking for your gaps in knowledge on a regular basis, prioritizing them? And then how are you going to go about, indeed selecting the appropriate resources from the literature? And indeed, how do you do that in the setting of an electronic database? How well skilled are you already in the ability to do that? That might be a skill you want to develop. It will be critical. What's the stuff that you're reading in real time? What are the journals that you're actually getting in the mail or electronically that you're reading on a regular basis? And are they appropriate? Are they enough? Are they not enough? The question will be, how many can you really do? Do you use systematic reviews or best evidence-based literature instead of just, sort of the monthly journals that come in? I think you need to pay special attention to the proper use and interpretation of tests, especially new tests. It's become more and more of an issue that people misunderstand and misinterpret tests because they don't fully understand the qualities of them. And then I would argue you need to develop a personal filing system. And I would actually add that I think that system needs to be not just electronic. I think I still have vanilla folders that I actually put information into, sometimes case material that needs to be HIPAA regulated. You don't want it in a database. Sometimes because you found a special article, made a copy of it. I like reading, not off of just the screen, but paper. There are opportunities where paper still plays a role. And I would actually argue your filing system should be mostly electronic at this point, but don't forget a good old fashioned manila folder with some articles or materials that you've collected that can fit in there. And then of course, I would also argue that part of your individual learning plan is a commitment to really transforming all of your learning into teaching. That is, convert the information that you've gathered to consolidate it and to really use it by teaching it to other people. I think that that's absolutely critical. And I would actually also add an element of formalizing your diagnostic reasoning process. And indeed, we'll be spending a fair amount of time on that later in the workshop, talking about that specific subject. So again, I'm not going to spend a lot of time. This really needs to be done within the context of each of your subspecialty workshops in RATTLE Part 2. But I would ask you to, again, reflect on what resources are you currently using on a regular daily basis. Are you dropping into PubMed, and do you know how to search the PubMed database so that you can do a search quickly and indeed usually get the information you need? Do you use the Cochrane Systematic Review, which I believe is the gold standard for systematic reviews in your particular area? And if you're not, how can you better start utilizing something like the Cochrane database? Dynamed Plus is an excellent evidence-based resource that's readily available across the network. I think it's really critical to potentially use that. I know most of you will drop into Google. I used to disparage that a lot, but actually Google scholars become quite good. And indeed, I would not just dismiss it. And again, I just mentioned, what's your basic ongoing journal reading, and is it too much or too little? Up to Date is a tool lots of people use. It's an electronic textbook. It has all the weaknesses of an electronic textbook. The only strength is it's a little bit more up to date, but it's still a textbook. So I would be careful about its use because it has issues with evidence-based medicine. And then, of course, we utilize a very specific framework at the School of Medicine that I'll just show you in a second. Again, I don't think I need to review this with everyone, but the idea that individual studies from monthly journals is probably the lowest yield. The highest number of articles are in this category, but it's the lowest yield. And I would really encourage you to make certain that in your reading on a regular basis, you're doing systematic reviews that have done a lot of the heavy lifting of eliminating articles that really aren't worth your time, energy, and effort. The School of Medicine uses a framework called Finding Information Framework, where it takes questions that get raised in the course of taking care of patients and categorizes those questions as either background questions, which is basically underlying pathophysiology, genetics, basic molecular principles that underlie what's happening clinically, and then foreground questions, which are probably most of the questions that come up in a clinical setting. That is, what's the best way to approach this particular symptom or sign? What's the best way to deal with this particular disease in terms of evidence-based guidelines? It's a useful tool in terms of sort of distinguishing questions, and you'll hear the students using it. So I just wanted to be certain that you were aware of that specific model. I did point out explicitly the issue of diagnostic tests and tools. I think it's absolutely critical that your individual learning plan include a little trip to the laboratory every time you run into a tool or a test that you've not used before. So just for example, the CBC that we use so frequently, my guess is that most of us don't really know exactly how a CBC is done and what the actual parameters are that are measured and how they're measured, just as one example. And then of course, the context of using a CBC and its usefulness in the specific setting that you're using it. I think that's important for common tests and and even more important for unique tests that we're utilizing. So I really would strongly encourage that your learning plan have a line about making certain you understand the reliability and validity of a given test, its sensitivity and specificity, positive, negative predictive values, and of course, if there is a likelihood ratio that would help you to apply pre and post test probabilities of disease would be incredibly useful. I'm not going to spend a lot of time discussing diagnostic tests. This is something we'll talk about in diagnostic era in the third workshop we do, but I just want to be absolutely clear that everyone is indeed cognizant of the fact that the reason we do any test is it changes our post-test probability of disease either up or down. And indeed, getting that pre-test probability is really a critical part of what we do. And indeed, finding that or having an understanding of what that is really important and should be part of our individual learning plan. I have no intentions of going through Bayes' theorem, but you do need to understand Bayes' theorem underlies all of that reasoning of pre and post-test probability. I don't expect you to know Bayes' theorem per se, but you really do have to understand that indeed this is what tests are all about, and understanding tests down to the fundamentals is so critical. And again, I often hear, if test positive, they have the disease, and obviously that's totally incorrect. I always love Benjamin Franklin. Certainty is clearly not a myth, both in diagnostic testing and in diagnosis per se. And as I said, we'll talk about this more when we talk about diagnostic error, but indeed misinterpretation of tests has become a major part of diagnostic error. And another piece of your homework for a workshop a little bit further down is to sort of reflect on when you've seen diagnostic error, either by yourself or by other people, what was the underlying cause, and we can talk about how we potentially can move to prevent that. So with that said, let's just touch real quickly about your own personal organizational principles. I think I've listed to a large extent all the things that potentially can go into your personal filing system. As I said before, you need something probably more than just electronic for some of these resources, but you really need something that centrally organizes and controls all the stuff that you learn every single day. And I would argue whatever it is, it needs to be fast, cheap, retrievable so you can get the information back out when you need it, flexible, and most importantly, readable, since information indeed has an expiration date. You need to be certain that you keep that database up to date. And there's many opportunities for you to do it these days. But again, one of your other pieces of homework will be, how have you created a personal organizing system? What database have you chosen to use? How are you putting the information in? How are you retrieving it? And indeed, are you using paper? And if you are, for what kind of material? So that's your other homework assignment that you have. So obviously, making teaching a part of your daily learning is really, really critical. And indeed, we're going to talk a little bit about these things in a second, but I did want to just summarize for 1 minute just the 10 commandments that I would argue are critically important to lifelong learning. And again, I've gone through all of these before in the course of our discussion, but I really think this is important for you to recognize that you really need to be a self-motivated, organized learner, always curious, obviously, to serve your patients. Use I don't know on a regular basis. Use diagnostic reasoning, formal diagnostic reasoning as you move through this process. You got to obviously understand what a test really says in a specific context. Obviously, you need to read the general literature every day for general facts, but more importantly, you need to query the literature in a critical fashion as you move through this and using the best available. Somebody's not muted. If you just background noise, please. And then, of course, you need to consult people all the time. Consultants can be a great source of learning, but I always encourage people to have specific questions. Organize notes in conferences and try to put that into your filing system. Getting information in your personal organizing system every day, and of course, teaching others every day is absolutely critical. And again, I've already given you homework a couple of times, so I think you sort of already know about that, which is really absolutely important. So this is all really about building that bridge of knowledge to the future. And I think it's absolutely critical, and we'll be revisiting all of these subject areas as we move forward. And with that, I am going to pass this over to George. George, I think one of the slides jumped. I don't know how that, I'll move it for you. Hang on. Hang on 1 second. Yeah, because that's a rather important slide. And with that said, I'm going to pass this over to Dr. Knoll, who's going to now switch gears a little bit and start talking about Teaching 101. Before I do, any comments or questions from the crowd in terms of having a personal filing system and a lifelong learning plan? Any of that resonate with all of you? Does anyone want to volunteer what they're doing to have a lifelong learning plan? You could just unmute and jump in. It's one of the reasons why I do not like having cameras off and this in Zoom, since I have no idea what any of you are thinking or hearing, which is always frustrating. Would anyone like to jump in real quick before we move on? Okay, Dr. Knoll, it's all yours.
Okay. Am I co-hosting it that I can advance slides, or somebody doing
I can. I got them.
Okay. All right. So making teaching a part of your daily learning, adult learning principles, theory behind that as an adult learner, and I've taught adults at the JFK and laboratory training programs, and they want to do problem solving. They don't want to just be talked to. They want to get involved with, with the class. There's different tools and communication skills and ways to facilitate that type of classroom. We'll talk about the NOLE model and the 1 minute preceptor, 1 minute learner, and the Stanford faculty development model was different models to get organized. I think we'll just do the NOLE model in this, and the other ones are in some other session. So if we move ahead. So the basics, learning objectives again, is we wanted to define actually, what the specific, learning objectives are. And, there's a way to be smart about it. And we'll, that acronym will go into detail. And, when we go ahead into the next slide, we want to define also, there's 8 competencies that are critical, and relate to the more detailed educational program objectives. There's 64 of these, and all that is the backbone of the School of Medicine's curriculum. And we'll put this into perspective how I, see it and get better understanding of this. And they demonstrate how those competencies are in the big picture of teaching, and show then the entrustable professional activities, the EPAs that fit into your teaching plan, and how critical teaching skills, use questioning and communication behaviors, to encourage involvement. So on the next slide, we'll see what SMART, goals are. And why do you really have to have a SMART goal? Why does it have to be specific, measurable, achievable, realistic, and timely? Because if somebody, for example, your lead, physician in your group is, in a pulmonary group, and they just say, yeah, in 2 or 3 weeks, some of you are going to demonstrate a pulmonary, procedure that you've learned. And you're going, what could this be? You have a lot of angst about it. You don't know what's going on. You're trying to study all these different things. But if the same person goes and says, well, 2 weeks from today in our same session, I'm going to have the three of you demonstrate, how to intubate a person, how to put in the insertion tube, how to connect up, the equipment, how to set the right settings, and that's what you're going to be evaluated on. Now it's specific, it's measurable, it's achievable, and it's realistic and timely. And every job I've ever had, whether it be in research, teaching, hospital work, sales, marketing, everything, all my goals are all based, on SMART goals. It's an industry standard across everything, not just, education out in the corporate world. So it makes sense because it takes a lot of angst away from, the individual learner, and they know, what's going to go on and what they need to do. So if we go ahead, so self-directed learning or teaching has to be organized. Just as Dr. G said, the individual learning plan, I'm sure you guys have some things to, to put together in your plan or whatever, but maybe you were having that morning coffee and didn't want to, speak up at this time. But for, the students you're teaching, you need those guiding principles. There's a homework question, and whatever we're going to be doing with this coming up, so the question becomes, what do you think are the essential things students should know or be able to do before they finish their clerkship in your specialty? And bring this list to the workshop. And this gets into what competencies you have to perform that are very important. And these are the EPOs, EPAs, and the other acronyms in there that go into the basic competencies, that people have to learn when they're in, the residency. So on the next slide, okay, we have our little gnome, and I call him Freddie because we got to put that F in there. This is a pediatrician's model, but I named him Freddie because you have goals, you have what the need is, you want your objective, you want how you're going to do this, and then you want to evaluate the person. Now, if you just evaluate the person, you scribble it on a piece of paper, throw it in their file, and never tell them what their good things are, what their bad things are, what they're doing, and you don't have that F in there for Freddie for feedback, they don't know what the heck's going on. They keep repeating the same mistakes over and over again. So the important thing is to have that feedback, with the individual, learner that you're, trying to teach, so that they're getting it or, they're not getting it. And coming across here. So the way I see this now, 3 to 5 years residency in medical school is a hierarchy. So if we look at, to put all this into perspective, there's 8 competencies from the ACGME. There's EPAs, entrustable professional activities, 18 at our School of Medicine. And there's EPOs, educational program objectives, 65. That's the foundation of the entire School of Medicine curriculum. So if I look at this in my eyes, if you have a big funnel, right? So at the top of the funnel, you have these 65, educational program objectives, right? Which are essential and the basis of all the curriculums, all the different courses, all the things that come together, right? Attached to that, right below that, that link to that, is the 18 EPAs, the entrustable professional activities. So if you do those things, then you're going to be demonstrating the competencies below that of the big 8, right? Which we'll see, coming up, and also, go into at the center of that big 8. And we'll see in a nice little diagram what comes down to the tip of the funnel is patient care. Great quality patient care. So you have your educational program objectives of 65, funneling down into your 18 encrustable professional activities, building on the competencies and satisfying those competencies of big 8, right? And then the whole thing, you have great quality care. So that's how it all sort of comes together for me. So I hope that's, a nice little picture, so at the bottom there, I hope you got it. Okay, so the next slide comes up, it's based on competencies. You got to do things, you got to perform these things. And and the training or so, what used to be that you started out, you're a novice, right? You learned, you get up to your boards, you're competent, right? So at that point, you said, okay, I'm competent, I'm satisfied, I can do the things. But since you have a changing, forefront of science and medicine and technology and healthcare systems coming together, right? You can't stop learning at that point. You really have to be a lifelong learner to be proficient and then hopefully be an expert at some point down the road. And like you said, after, Dr. G said, after even 40 years, you're going to be things of saying, I don't know, let me look this up and keep learning things. Let me take a course on this. Here's a new, software that I need to know, right? So I have to take, an online course or a class and sit in to do this. So it's, you've got to keep, that, competency, fresh and, be a lifelong student and a learner. And if we go ahead, right, here's our 8 core competencies. And what is at the heart of the matter, in this, concept, diagram, concept map basically is a diagram, a flow chart. And you've seen this probably in, computer programs, project management, layouts, same type of things. But right at the heart of the matter, right there is patient care. In every mission statement, of all our hospitals and all your practices or so, is giving good quality patient care, right? And how do you have to do that? You got to know what you're doing, you got to communicate, and you got to be professional. And then outcome from that, in a close, association with it, you're in a system. So you're in the healthcare, Hackensack Meridian healthcare system, you're in the RWJ Barnabas system, our competitor, Atlantic Health System, Northwell Health, Summit Group, whatever, right? You have to work within those systems. All those systems may not use Epic. They may use Cerner software to document things. So you got to learn that. And that's how your self-directed learning comes in. And the practice-based things, certain physicians may do certain administrative things and say, well, no, you can't put these insurance things together, and do these certain tests. You have to only do this first and this second. So there's collaboration and interprofessional, working with colleagues, not just for, some of the technical stuff, but then it gets into also, well, I'm not sure about, this treatment plan. I can go 3 different ways. Let me talk to a couple of these different colleagues and see what's going on. And it may not be just, a physician, it may be, the PA and the nurse too. So 65, entrustable professional objectives all together again. Again, I see that as the top of the big funnel leading into the 18 and then down to the 8, down to patient care. So the vision and mission of the school drove the creation of all these EPOs. And that's the outcome of the curriculum. And the students have to perform those specific competencies that they can, graduate with at that point. So it shows that they're ready, for their practice. And the EPOs were really the second step in creating right after the mission statement, for the school. So entrustable professional activity, another acronym, EPO, what simply defines it there as a core unit of work, reflecting the responsibility that should only be entrusted upon someone with adequate competencies. So again, those, EPOs, there's 18 of them. And if you do and, are competent in those areas, right, you're satisfying the 8 core competencies and giving good patient care. So independently executable in a certain time, observable and measurable, they're SMART, activities are based on the EPOs. They require sufficient knowledge, and they are usually confined to the qualified personnel. And if you can do those things and complete those different things in that structure, right, you're, qualified at that point. And if we go ahead, right, so the AAMC 13 entrustable professional activities, and there's actually 18. We say, wait a minute, where's the other ones there? And we'll get to that in a minute. But it's basic operation of what do you do when a patient comes in, right? You do a history, do a physical exam, right? You may order some tests and prescriptions. You may look at those tests to find the diagnosis and interpret type of things. You listen to the patient, what are their symptoms? What's their problems? And then you record this stuff. And you may present this orally, to somebody else, because medicine is a team, practice. And you question, of what's going on. You may hand it over to some transition care. If you have, a comorbidity that's a long-term thing, like diabetes or COPD, there's more wider scope, and you collaborate, so of course, you recognize immediately any urgent or emergent care. So you're running a lab test and, a person has an anaphylactic shock to an injection dye, you're going to take care of that immediately, and not worry about, what his transition care is after this. Okay. So if we go further, of course, you got to have informed consent. You have to know the general procedures and identify any failures. Identifying failures is a system called high reliability organization training, which Hackensack Meridian does and other hospitals do. And what it is basically is, a system of process checks, checks again, and rechecks. And it sort of, came from other industries like the military and the aircraft industry. And this gets to the heart of, errors, that was mentioned earlier. And I think there was a fact or so that, the third leading cause of deaths actually is done by errors in the hospital, right in the behind heart disease. And for various reasons, maybe as simple as just, putting a decimal point in the wrong spot for a prescription. So there's ways of getting around this, not writing things like CC, would write out milliliters of something, and make sure that you're not using certain abbreviations. It's one component of that, but we won't, get into the detail of that. We'll move ahead. So more of the EPAs, our School of Medicine said, well, wait a minute, there's some extra things here, for the human dimension. You should have more communication skills for cultural humility. You should have patient education, and teaching for chronic disease management. How is a person going to manage their diabetes, or, their care after a heart attack, and cardiac care or rehab care. And also, professionalism and growth and connecting that humanism with the community. So for example, a grandmother that lives alone in an apartment down in Newark, may not be that up on, saying, oh, well, I can't determine, how, to take all these different types of medications. And I won't remember, that my appointments are, next week or whatever. They need help in doing that. Maybe a chart system or a reminder of the office calling them that they have certain things coming up. Whereas a grandmother that has an extended family with grandchildren and, their kids, in, Montclair, New Jersey, would be saying, oh, we have a lot of help in the family here. Hey, grandma, you got to go next week. We'll take you, for this exam here. Oh, you got to get blood work again. And here, make sure you take these 3 medications today, because you got to take them every day. So that's looking at, the person connected with their community and family and surrounding, and that human dimension, which is so important, and goes throughout our training, in our School of Medicine.
George, can I just insert
Sure.
here just for a second?
Yeah.
So again, I think whenever we start talking about, all of these educational terms, I think to a large extent, and I don't have your cameras on, but I probably can sense that, the eye rolling happens and it's like, what is this? And how is this germane to me, in my residency and my teaching of students? And I think it's important to make certain that everyone understands, the core competencies that we talk about. You're living in a competency-based educational world now. The first question that's going to get asked of you by your residency reviewers when they come into your program is, can you please tell me the 8 core competencies? So that is not theoretical stuff or, something that gets on a shelf somewhere and only the educators know about. Every single one of you must be able to recite the core competencies, because all of your education is really structured by those 8 core competencies. And as I think, as George mentioned, the School of Medicine began by actually listing the sort of sub-competencies below the 8, which gave us the 64 or 65 EPOs, which are really important. And then why we then went on to create entrustable professional activities is, if you look at the core competencies, they're big things. They're not particularly smart in the sense of being specific. They're really quite broad. And it was felt that in order to really do evaluation effectively, you really needed something that was more specific and indeed more measurable, and indeed was sort of the things that we can observe. And that's why the entrustable professional activities were indeed developed. A bunch of people sat around a room and said, what do we do every day? You know, what do we have to evaluate that students and or residents need to do in order to function as physicians? And that's where the entrustable professional activities came from. So for example, the very first entrustable professional activity, to do a basic history and a physical exam, requires multiple competencies. It requires you to be a professional, to be able to have enough knowledge about how to do those skills. And it requires, to a large extent, good communication skills. So almost all of the entrustable professional activities are composites of multiple competencies and get translated into the actual work that we do. And why it is so critical, and why you really need to not just sort of let it go by and really appreciate how important they are, is the entrustable professional activities become the backbone of how we write learning objectives for the clerkships, which you need to know, and how we write the evaluation tool in terms of assessing students and indeed yourselves. The entrustable professional activities are now going to become the backbone of your evaluations. So these are not esoteric, out there educational ideas. These things are going to be things you're going to be seeing in your own evals and in the evaluations of the students. So it really is important that everyone, sort of get a sense of these. And I would strongly encourage you actually to go back over these slides and really think about the entrustable professional activities and the educational program objectives. And actually another homework assignment, which I mentioned before, is about, well, what do you want your students to learn? And I would actually ask you to try to frame them in the context of these 2 ideas that we've just thrown out. So with that said, we're going to change topics slightly and talk a little bit more, not just about the organization of educational process, which is so critical, but also the other basic skills absolutely critically essential for you to be an effective teacher. George, I'm sorry to interrupt, but I just really wanted to make sure that that point got across. So why don't you pick up where we left off? I apologize for eating some of your time.
No, we thank you for that, to clarify it, because it does get muddled, when you mention all the acronyms, and it's good to have another person jump in to clarify. So what do you need to be a good teacher? We have simple basic skills, how to structure and use questions, how to communicate effectively and get feedback and in a positive learning environment. You don't want to just stand up at a lectern and just spit out information. Why questioning? Because you can get into a dialogue, with the learner, and you'll get them back and forth. So you have an interactive, and you become more of a person that facilitates a conversation between the student and yourself. And they're the most useful things, the questions, and actually misused if you don't do them in the right way. So it comes up on the next slide here. We have a question for you. And
I think we're going to run out of time, George, if we talk about the Brooklyn Dodgers. So okay. I think we're going to have to regrettably miss the Brooklyn Dodgers today. But I have a strong bias towards the greatest team in baseball, but some of you may argue about it. But I do think we need to. I stole enough time that the Brooklyn Dodgers got to get kicked out. Sorry.
So so you say they were unique, for various reasons. Effective use of questioning, and we move on. And you have to have a disciplined question. You got to have a question that is not just a yes/no answer, and we'll mention open and closed questioning. And, if you just say, name how many bones are there in the human body, or how many nerves come off the spinal cord, that's a factual thing. It's a yes, no, or, a fact. But if you say, describe, 3 of the nerves that come off, the human body and what what their function is and where they connect to, or explain or compare and contrast, those type of questions are more deep and make people think and get into critical thinking, which is important. So on the next one, we see the goal of questioning then, as I just said, is to get the critical thinking, and make the person think, not just spit back an answer, okay? And on the next slide, we see, that these are probing questions, probing for reasons, rationale, viewpoints, conceptual clarification, those type of things. When you get into compare and contrast, discuss, the topics of, why is, monkeypox now considered, a global, emergency by, WHO, so it opens up a whole avenue of things. Open and closed questioning, you get into this in a sales situation. You go into, buy a car, and the salesman comes to you and shows you the most loaded vehicle on the lot. And he says, oh, it has this, 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 this. You want to buy this? And what do you say? No, not really. And you move on to someone else. But if the person goes and says, hey, what are you looking for? Tell me about, what type of vehicle you want. And it's the same thing about, someone going into a laboratory and trying to sell, a researcher or a physician a piece of equipment. If you go in there with all a bunch of brochures and say, we got this great new analyzer and this and that, says, hey, I don't have time right now, go see someone else. But if you're talking about their work and you get into, how can we make your work easier? And, what problems do you have? Well, we want to do a higher output, of screening, these samples. Well, we have an instrument that just came out. Would you be interested in that? And that's the difference between the open and closed questioning, mainly used, in marketing and the sales areas too, but it works across the board, with things. You want to keep them open, type of questions. And in the next, slide here, we'll see that, Bloom's taxonomy, the knowledge base, that we all came out in grammar school where, okay, the teacher spits out stuff, you memorize it for an exam, you spit it back on the test, then you forget about it, you're for the next week. That's not really learning and education. You want to be able to understand it, comprehend it, apply it to things, solve problems, synthesize those things together, and then make a judgment call, the evaluation. And that's where you really, sweat it out, because it's like, hey, do I go down this, treatment path or these 3 other treatment paths with this patient? And it has to have all different types of input from that, from colleagues, from information, from tests, and you're putting all these things together. So the idea is to move up that pyramid and get to that, top evaluation, judgment type way of critical thinking. So as we said, the bottom levels are just basic needs. As you go up, you do more critical thinking. You want to get to that top type of high level thinking, to really make things work. And when you throw out questions, you want to wait for an answer. So if you say, hey, what do you think about, the WHO declaring, monkeypox as a global emergency, right? And somebody says, and you wait 3 to 5 seconds in person. On Zoom, you got to wait about 10 or 15 seconds, but don't jump in and say, oh, nobody's answering. Well, I'll tell you, then you're giving them the answer. And if you do that more repeatedly in a classroom, you probably had this in undergrad where you say, hey, this professor's just going to tell us everything. We don't have to answer your questions. We'll just sit back and just, let him do it all. Right. So you have to go and let them participate and stuff. Okay. And if we go ahead, right, have all these tools, silence is golden, for it, have that, 3 to 5 seconds in person, 10 to 15 seconds, hear the crickets, and then let them respond. Observe, what's going on, have eye contact. Are people falling asleep, or people on their phone, getting their email, whatever, not really paying attention. You got to wake them up, so it should be active listening. You got to summarize, what the learner is telling you too when they're answering back, and say, oh, your position on this would be this. Okay. And if we go ahead, so positive, safe atmosphere, you want eye contact. So you want to tread between, a caring personality and challenging directly. So you don't want to empathize and say, I agree with everything. And you don't want to knock down everything and say, hey, you don't know anything. Let me tell you everything. You want to have that fine line between caring and challenging directly, a balance between, the two, so that you have a good dialogue between, the learner and you as a teacher. And I think there, and then we have our, nice, safe environment, so that yes, you can speak up, you can, disagree, with the teacher. You can go back and forth. The teacher can disagree with the student, but you got to listen both ways and, participate in that back and forth interaction. And I think we come to our break.
Yep. Actually, we're going to stop right there. I want to be respectful of everyone's time, because I know everyone's got to run off for a whole bunch of things. But, I think I'm going to leave this slide up for just a second, because indeed, you really affect the learning environment by doing a lot of the things that we were just talked about. Admitting your own ignorance is one of the most effective ways to create a positive learning environment, because everyone realizes that they can indeed ask questions and not know. And indeed, having an environment that indeed includes everyone is just so critical. It's one of the greatest complaints that we see at the School of Medicine, is they get environments where their students are ignored, or they're ostracized, or treated with disrespect. And obviously that's something that we need to avoid if we're going to have an environment that's absolutely critical for everyone to learn. And again, it's so critical, I think, for everyone to really have this lifelong plan. They really need to have a plan in place. You really have to have an understanding of the competencies that we've talked about and the entrustable professional activities. We've given you a little touch of some of the basic skills that you really need in terms of using higher order questions and communication skills. Zoom is not the place to teach communication skills. A bunch of blank screens with names on them, talking into a camera is not the environment. We'll do this in our personal workshops. We'll actually work on some of those communication skills directly. So hopefully that opportunity will come up. And as I've mentioned already several times, Rattle, the rest of Rattle Part 1 will be a series, 2 more series of discussions like this. And then we'll be meeting in Rattle Part 2 in the latter part of the academic year, in person in small groups run by your various Rattle champions within your department. For those who haven't done this already, I really would encourage you, make sure to put your attendance down so we have a record of that. I thank you all for taking the time to join us this morning. And most importantly, I look forward to the opportunity as we move through the next 2 workshops to then move out into the real world and meet all of you in small group settings where we really can actually work on these skill sets, work on communication skill sets, talk about your own personal self-directed learning plans, discuss what you think is most important that students learn in your clerkships. And then obviously in the subsequent workshops, we'll talk about how to organize that process and indeed evaluate students, which is a whole nother topic that we'll be touching on shortly.